Welcome to MediCrush, where I help you crush your medical examinations. In this video, we will cover coarctation of the aorta. Coarctation is a fancy word for describing narrowing of the aortic lumen at the distal arch or the descending aorta. This narrowing usually occurs at what is known as the aortic isthmus. An isthmus is an area that connects two larger areas. So the aortic isthmus is the area that is just distal to the left subclavian artery, and it ends at the ductus arteriosus. Kind of very similar to the Isthmus of Panama, the country where I was born. Isthmus of Panama connects two larger bodies of land. So this aortic isthmus is where most of these coarctations occur. Very important about this is that the narrowing occurs after the aorta has given off branches to the head and the arms, such as the subclavian arteries and the carotid arteries. Clinically, that means that coarctation of the aorta is associated with high blood pressure in the upper extremities, but low blood pressure in the lower extremities after the narrowing. About 70% of these cases are known as preductal, where the narrowing is proximal to the ductus arteriosus. We call that the infantile type. 30% occur after the ductus arteriosus, so we call that postductal, and that may also present later in life, such as older kids or adult type. We don't fully understand what causes coarctation of the aorta, but a majority of these cases are going to be congenital. Very rarely can you acquire coarctation of the aorta. In this case, it is usually in the setting of a large vessel vasculitis known as Takayasu arteritis, because Takayasu arteritis predominantly affects the aorta and the branches off of the aorta. It is more common in males, and about 4 to 6% of all congenital heart disease is going to be due to coarctation of the aorta. There's some very important cardiac associations with coarctation of the aorta, and the first and most important is a bicuspid aortic valve. About 70% of patients with coarctation of the aorta will also have a bicuspid aortic valve. A normal aortic valve should be 3 leaflets. Some people, however, are born with fusion resulting in 2 leaflets, known as a bicuspid aortic valve. Some other cardiac associations with coarctation include a patent ductus arteriosus, or PDA for short, ventricular septal defects, or VSD for short, and mitral valve issues. A genetic condition associated with coarctation of the aorta is Turner syndrome, also known as monosomy X. In this condition, a female is born with an absent or a non-functional X chromosome. In terms of the pathophysiology of coarctation, it does not usually rear its ugly head in utero just because 2/3 of the combined cardiac output flows through the patent ductus arteriosus into the descending aorta, bypassing the narrowing or the coarctation of the aorta. And that's because that is the normal flow of fetal blood flow through the ductus arteriosus. However, at birth or shortly thereafter, when the ductus arteriosus and the foraminal valley begins to close, the cardiac output now has to go through this narrowed segment of the aorta, and that can result in issues. The 3 main issues that can occur with this is that you have this increased blood pressure proximal to the constriction, which results in upper extremity hypertension. Because there's less blood flow distal to the narrowing, you're going to get decreased blood flow to the lower extremities. Your body says, wait, I got to fix this. So is there a way I can kind of bypass or circumvent that flow to kind of basically offset the loss of blood flow through the narrowing area? So what happens is your body can start to use collateral blood flow through some other arteries, the most important being the intercostal arteries. And that compensation or increased blood flow allows to deliver blood to the lower extremities. However, over a period of time, this can result in this left ventricle pressure overload due to increased afterload, and that results in left ventricle hypertrophy. If the left side of the heart is pushing against this higher pressure, it will get strong as any muscle would, and you get hypertrophy. This systemic hypertension and LVH can eventually lead to heart failure. Now, how they present depends on a few factors, such as how severe is the narrowing of the coarctation, as well as is there supply via the collateral blood flow through the intercostal arteries and other arteries. In its most severe form in neonates, they may present with cardiogenic shock, heart failure, or failure to thrive. On examination, they may have cold or mild lower extremities. In older infants and young children, they may have no symptoms and it may be picked up based upon having high blood pressure or a murmur that is associated with coarctation of the aorta. In some cases, they may even have chest pain, or they may describe this leg discomfort with exertion such as ambulation, and we call that claudication. In adults that may not have presented in childhood, they may be presenting with only just systemic hypertension, also known as secondary hypertension. In this case, the cause is due to coarctation of the aorta. Now, this hypertension may manifest as headaches due to increased blood pressure to the head, epistaxis, or even just the high blood pressure readings. The lower extremity decreased blood flow may represent as lower extremity coldness, for example, or even bilateral claudication. The patient may describe leg discomfort or pain with ambulation or with exertion. And that's just due to decreased supply in a situation of increased demand. Cardiopulmonary symptoms may include chest pain, fatigue, dyspnea and exertion, or even syncope. Very rare complications of coarctation may include aortic aneurysms and dissection or tearing of the lining of the aorta. On examination, there are three key feature findings. The first is going to be the upper extremity systolic hypertension. The second is the lower extremity hypotension, which means if you have those two things, there's a significant difference between the upper, such as the brachial artery, and the femoral artery blood pressure measurements. In addition, they will have a weak and delayed lower extremity pulses, and this is known as brachiofemoral pulse delay. So those are the three key features: upper extremity high blood pressure, lower extremity low blood pressure, and delay in weakness of the lower extremity pulses compared to the upper extremity. In neonates with severe disease, they may present with hepatomegaly due to right-sided heart failure. They may have decreased or absent femoral pulses, and they may even be diaphoretic and dyspneic. On examination, a classic finding is a harsh systolic murmur, often heard along the left sternal border, and it may radiate to the back or between the shoulder blades, the scapula, and even to the chest itself. Now, additional findings may depend on what other cardiac defects are also associated with coarctation of the aorta. If there's mitral valve issues, they may have an ejection click during systole. If it has a bicuspid valve, they may have a systolic ejection murmur of that as well. In females, you should look for evidence of Turner syndrome because 5 to 15% of females may also have Turner syndrome. In neonates, that can manifest as congenital lymphedema, webbed neck, or low set hairline. In older children and women, that may manifest as a short stature. They can have a broad, what we call shield chest, where the nipples are far apart from each other, and they may have a webbed neck and even may have delayed secondary sex characteristics. To pick up coarctation of the aorta, the most important non-invasive test is going to be an echocardiogram. It will show evidence of the narrowing of the aorta as well as look for other congenital heart issues that may be associated with coarctation. We often order an ECG and chest radiograph, but again, the key finding for this is the findings of narrowing of the aorta on echocardiogram. Now, chest radiographs in neonates may show evidence of severe heart failure if it's really bad, and that can include increased pulmonary vascular markings due to pulmonary hypertension and cardiomegaly. The classic radiograph finding of coarctation of the aorta is a posterior and inferior rib notching. And that's where you have this inferior rib erosion due to these enlarged, dilated, and tortuous intercostal arteries as they try to attempt to provide collateral blood flow to the lower extremities. In addition, they'll have the classic figure 3 sign, and that's where the coarctation or indentation of the aorta looks like the notch of the number 3. The EKG may be completely normal, or it may show evidence of left ventricular hypertrophy due to this increased afterload. The narrowing results in higher pressures. Angiography is the criterion standard. However, it is not used often just because it is very invasive, and we often get a lot of information from the echocardiogram, which is non-invasive. In females with coarctation of the aorta, genetic testing via karyotype analysis is often performed to rule out Turner syndrome due to the high association of coarctation with Turner syndrome, and also because not all females with Turner syndrome will have the classic findings on examination due to mosaicism. Coarctation of the aorta is a clinical diagnosis based on the presence of upper extremity high blood pressure, lower extremity low blood pressure relative to the upper extremities, as well as the brachiofemoral delay that decrease, as well as delayed pulses in the lower extremities compared to the upper extremities, especially in the setting of echocardiographic evidence of coarctation of the aorta. In infants less than 4 months of age, the preferred management of coarctation will be surgical repair of the narrowed area, and that can be done via end-to-end anastomosis with resection of the narrowed segment. However, prior to surgical repair, these infants are often given a prostaglandin E1 medication because that helps to do a few things. It helps to maintain patency of the ductus arteriosus, which allows to improve blood flow. It also helps to decrease some of the narrowing of the coarctation, and again, it helps to relax the isthmus to allow for blood to flow much better. So oftentimes they're given a prostaglandin E1 analog prior to surgical repair. In older infants and in adults, then this repair could also be done via transcatheter-based intervention, and that could be done via balloon angioplasty with or without the placement of a stent. So now that we've gone through coarctation of the aorta, I want to test your knowledge by a few questions. So for this section, what I want you to do is to pause the screen when you see the question. That gives you enough time to answer the question, and then I will go over the question with you and explain to you how to think through this question in the mind of a test writer as opposed to just being a test taker. Which of the following physical examination findings would most likely be present in this patient? Young kid that has claudication in his lower extremities, high blood pressure, you should be worried about coarctation of the aorta. So we expect they would have upper extremity high blood pressure, lower extremity low blood pressure, and that brachiofemoral delay, that delay of the femoral pulse in relation to the brachial pulse. Which of the following examination findings would most likely be seen in this patient? A 19-year-old female with hypertension, headaches, and claudication, and decreased pedal pulses in the lower extremities. You should be worried that they probably have coarctation, and we know that females have a 5 to 15% chance of also having Turner syndrome. That may manifest itself as a webbed neck, a short stature, a shield chest, and even delayed secondary sexual characteristics. Which of the following is the most appropriate next step in the management of this patient? 20-year-old female has this headaches, this systolic murmur, and pulses that are weak and delayed in the lower extremities. You should have a high suspicion for coarctation, and the most important test to make that diagnosis should be an echocardiogram to look for evidence of coarctation and look for other abnormalities as well. Which of the following would most likely be seen in this patient? 45-year-old female has hypertension, has the harsh murmur, and also on an x-ray you can see the classic 3 sign or the indentation of the narrowing of the aorta. So therefore, 70% of these women will also have a bicuspid aortic valve, making that the best answer here. Now, although dissection and aneurysms can also be seen with someone that has coarctation of the aorta, it is not as common as the bicuspid aortic valve. Those two complications are very rare compared to the bicuspid aortic valve. Which of the following findings would most likely be seen on chest radiograph? In this case, she has fatigue, hypertension, and cold and underdeveloped lower extremities, which are hallmark for coarctation of the aorta. There are two classic radiograph findings in adults, and that would be either the 3 sign or the rib notching, the inferior rib erosion due to the increased dilation of the intercostal arteries as a collateral flow. Choice A, boot-shaped heart, is hallmark for tetralogy flow, which is a cyanotic heart disease. Enlarged pulmonary arteries with increased cardiac markings could be seen with pulmonary hypertension in neonates with coarctation or in other conditions that cause pulmonary hypertension. A globular heart with a narrow mediastinum is hallmark for the classic egg on a string appearance that is hallmark for transposition of the great arteries. And a widened mediastinum could be seen in conditions such as aortic dissection, which will present with sharp chest pain that is knife-like and stabbing at that moment. Which of the following treatments would be most effective for this patient? Neonate presents with symptoms that are consistent with severe coarctation of the aorta, which means they need surgical repair. But prior to surgical repair, we often give prostaglandin E1 analogs to help to maintain patency of the ductus arteriosus. It helps to decrease some of the pressure on the isthmus of the aorta and also helps to reduce the symptoms of coarctation until surgical repair can be performed. Thank you for watching this video. Please like and comment. Let me know which part of this video was most helpful for you. Also, share with your friends. Sharing is caring. And last but not least, please subscribe to my channel. That way you can be notified when new videos are dropped. And as always, you crushed it.